Today, I don't know if you can see this fluoro image very well, but on this fluoroscopic image, this level is fractured where you see that little needle on the bottom, and the vertebrae have slid forward. So that's called a lytic, meaning he had fractures as a young guy. He had pain in his back since he was a teenager. He's now 64. He's always had back pain. It's very common when we see these people, they've had back pain their whole lives because they think it's normal, because this happens when they're young, sometimes age 8. The vertebrae slides off this tailbone, which you can kind of see how L5, the lumbar fiber, is slid forward off the sacrum because the joints are fractured off in the back there. The disc above it here at lumbar 4-5 looks pretty reasonably healthy. But if you notice the one above that at L3-4, he has pain related to that disc also. So what we're going to do, because the facet joints are normal at the top 2, is we're going to do artificial disc replacements there. He's actually a friend of mine. We were surfing in the Arctic Ocean together north of Iceland. So he wants to keep mobility of his spine and reduce pain. So I'm not going to fuse the entire spine. I want to maintain motion by placing artificial discs. So I'll place an artificial disc at lumbar 3-4, lumbar 4-5, and this bottom one, because the joints are broken, we have to fuse that. This is a hybrid, a combination fusion with disc replacement. See now how lumbar 5 is lifted all the way up. It used to be sitting all the way down and forward, and it's all the way up. Over there is Elena, wave, and she's monitoring his lumbar 5 nerves with motor evoked potential monitoring the entire time, continuous monitoring. She's telling me if I'm overstretching any nerves. But in fact, his signals have improved on the left where he was weaker. So they're getting better. So this is a good sign that I'm not over distracting or stretching the nerves. So here we have the bone graft we're going to insert. We've shaved it to be a little more lordotic to give the angle. And we place the center, which is open, with the bone graft, which is BMP, which is bone morphogenic protein. This is the human protein that makes bone grow, mixed with a little allograft bone and some demineralized bone matrix. We'll pack that in. And this will stimulate the patient's own bone to grow right through this implant and right up into the both vertebrae to provide a fusion. We like that right there. Now, vascular surgery does our exposures because what's in the very front of the spine are the blood vessels. We have Dr. Raj Rao here, who's one of our premier vascular surgeons who do these exposures, he and his associate. And they've been doing this for 30 years, and they expose the spines. They have thousands of approaches. So they're able to move the aorta, the iliac arteries, the vena cava, the common iliac veins out of the way because they sit right in front of the spine. I need those out of the way to fix the discs. So they're instrumental. This is the core, the dome. This is ultra high molecular weight polyethylene. You'll notice in here there's a small little metal bead. That's so you can localize it on x-ray because plastic is clear on x-ray. It slides in here. It'll slide down the rail. We will slide it into the implant and it will lock in with the final pusher. Screw it down. This opens the disc space as the core goes in. You can watch it on fluoro, shoot coming. All right, do live now. You can see it opening up. There we are, thank you. And now we'll lock the core into place. Shoot there. Let's give it a shot. Fluoro now. And if you notice, you'll see the little bead on the front. That's exactly where it should be, on the little round bead on the lower piece of black looking metal on the front edge. That indicates that the core is snapped into place and in the correct location. And you always visually inspect it. Allison, how do we look there? The poly is seated to the disc, correct? Okay. Okay, so if we're done with the disc replacements and the fusion, remember we have 2 artificial discs and a fusion on the bottom. That's a hybrid. You remember the reason we had to fuse the bottom one here and there is because the patient had a lytic fracture. You know, the lytic means fracture of the pars, which is the neck of the facet joint. So both facet joints were broken off. You need facet joints to hold an artificial disc, so an artificial disc would not be appropriate at that bottom level. So that had to be fused. We will take the remaining fractured bone off through his back, stabilize him with some screws to lock that together. That's his main pain generator. And then the artificial discs are finished. And they're in good position on front view and on side view. So he'll be very happy with this construct.